So I'm ready. So thanks so much for inviting me. It's always great to be here. When I saw the title of the lecture, Management of Severe Calcification, I wasn't sure whether you want me to talk about calcium, about the structure of calcium, whether calcium is a mineral or not. And so I came up with, and then I read that this is the enclave of the operator. So maybe you don't want to hear so much data. You may want to see some cases. And so I tried to put something together. So I tried to illustrate with this with 3 cases. So the first case is 63-year-old severe aortic stenosis, hypertension, no CAD. His SDS score is 0.77, so he gets enrolled. He refuses to be to be operated on. So adamantly refuses, rather die. So we enroll him in the CoreValve low risk registry. So we bring him in. You can see that this valve is very, very calcified, and he has 3 nodules of calcium here. So this is he really has severe aortic stenosis, so we decided to do a CoreValve Evolut R at 34 millimeters. So that's the final result. And then we look at the hemodynamics, and then we have this. So there's about a 20 millimeter residual gradient. So what's going on there? Any comment? So the first thing that we did is, it looks okay. The contrast is a little bit diluted. The wire is still across the valve, so that may explain a little bit the EAI. So
looks a little underexpanded.
Yeah. So we took another view, and you can see in this other view that the valve is really constricted by the calcium. Yeah. So this was solved by post-dilating with a true balloon. I think it was like a 22 or 20 or a 24 balloon, and then this is the final. This is the final result. We had almost no gradient, and this is a residual gradient. The residual gradient was 10 millimeters of mercury. So that's solved. Another quick case, 92-year-old. Now we're going into the high-risk arena. Hypertension, hyperlipidemia, class 2. Now the SDS is 9.1%, so high risk. He has 2 large bulges of calcium, and he has calcium extending all the way into the intersection with the mitral valve. So at the heart meeting, we decided to favor self-expanding valve, because then you may regret that you can push the calcium and then rupture the annulus. So we went with an Evolut Pro 29 millimeters. So this is a valve deployment. Everything goes well here. And then we have the self-expanding valve regret. Now we have lots of AI, and the LVEDP, as you can see here, touches the diastolic pressure. You have to do something about that. So again, we decided to go ahead and post-dilate with a 23 true balloon in this case. And we gave ourselves a pat in the back. Then the patient was doing relatively well. We sent him home. He had a little bit of bleeding, had a little bit of a rocky recovery after this. A month later, I get a call from the referring doctor that he found something weird in the echo. So, anything?
Yeah. Well, Richard?
Looks like a connection to the right heart there from the calcium getting pushed in.
Yeah. So we
fistula in the RV.
Yeah. So we pushed the calcium, and then we created a little communication between the non-coronary cusp and the outflow tract of the right ventricle. So we brought the patient back. We tried to go. We assessed the shunt. The shunt was very insignificant. The shunt was very insignificant. We did a CT. As you can see here, you see the jet. It was like a pinpoint jet. And the patient was still complaining of shortness of breath and failure to thrive, but then the shunt was small, so we decided to leave it alone. But again, these are the results of calcium. So severe calcification in the left ventricular outflow tract, the leaflets, and the aorta is associated with paravalvular leaks, root injury, new pacemakers, post-dilation, need for a second valve, and increased mortality. This is data from from CDARS that is showing the relationship between calcium and mortality, and patients that have severe calcification, moderate to severe calcification, have a higher mortality risk. Then they stratify between newer generation valves and older generation valves, and it seems that the ceiling that the SAPIEN 3, this is mostly a SAPIEN site, causes is better, and then the calcium may not be as influential as it is with the previous with the older generation valves. We know that the extent of distribution of calcium in the aortic annulus and the outflow tract also predict paravalvular leaks. And in this nice analysis, they show that with increasing overall calcification rates, there's increasing risk of severe aortic regurgitation. The risk is also there for pacemaker implants, and you can see that the distribution of calcium in the non-coronary cusp at the device landing zone is also independently associated with the need for pacemakers. And last but not least is that and this is also, I'm sorry, I got confused with the slides. So in this case, there was an association of paravalvular leaks with calcium, just confirming the prior slide. And now there's newer generation valves. It seems that the data from Lotus looks very promising for treating with calcium, and perhaps now we can choose the newer generation devices from the menu to treat the very calcified vessels. Here are patients that have a high calcium burden versus low calcium burden, and the patients that have high calcium burden, when they were treated with the Lotus valves, had significantly lower risk of more than moderate paravalvular leaks. So that's another important thing to keep in mind. Another case, so this would be in reality case number 3. So this is an 86-year-old man, severe aortic stenosis. As always, mild dementia, had CKD, has significant frailty. The STS score is about 3.5%. So this is his LVOT and the annulus. You can see that there's like a golf ball type of calcium there. And so we decided to go with, based on the area of 619, we decided to go with an S3 29 that would give us an oversize when inflated at nominal between 4.7 and 10%. So this is another view of the calcium, and you can see that the calcium is extending into the LV outflow tract. So we brought the patient in. Everything's going well. As you can see, we do a very controlled deployment of the S3. Then, so what do you think of the AR there? Would you do something about that, or just leave it alone?
It looks pretty severe. It looks severe.
Looks severe, right?
Yeah,
so
yeah,
it seems
especially on the non-coronary cusp.
So we decided to, I mean, the first thing that we do, I mean, correct me if you do something else, but we usually post-dilate the valve in cases, in these type of cases, and assuming that there's a calculated risk. So we went forward and dilated and post-dilated the valve with an additional CC in the balloon. And then the patient developed ST depressions. Then after the patient developed ST depressions, the patient developed, this was with MAC. You can see that after that he developed profound hypotension, and there are two things happening here. There's CPR, and you can see that here there's a wire going in, doing putting a pericardial drain. So we took a look with, we put the patient under general anesthesia. We brought a TE probe, and you can see that now we have a significant effusion. So what's happened? I mean, this case is a lot longer, but I'm just going to show you the highlights. So we identified that there was a rupture underneath the valve, and we were lucky enough that we were able to engage this, the rupture, the tear, with a JL5 guiding catheter. So after that, we just scratched our head and said, what do we do? So I tried to put an AVP, a 6 millimeter AVP, but that was not nearly big enough to be able to close a leak. So I called, so in this case, you start calling people that know how to plug stuff, right? So we called one of the radiologists, one of the interventional radiologists, says very quickly, he says, well, why don't you coil it? So he brought me a large coil that I've never used before. And then we started to deploy the coil. Here you have the deployment of a coil. And subsequently, this is how it looked. And the effusion now was gone. And we were able to aspirate all the effusion. The patient stabilized. He went home about 5 days later. He was extubated the following day. And we brought him back for a CT about a month later, and also to analyze whether or not this was impinging on the leaflets of the valve, because there's a little piece of the coil that is protruding in the outflow tract. But there was not increased gradient, and everything looked okay. So paravalvular leak, severe calcium in this nice paper by Barbanti is associated. There are two factors that had importance. So the most important factor associated with annular fracture is severe calcification in the LVOT, and then prosthesis oversizing of more than 20%. So then one last case. This is a lady, 90 years old, very feisty. We bring her in. You can see that there's a big ball of calcium there. We predilate. We put a 20 millimeter sapien. And you can see that the valve doesn't expand completely because there's this big chunk of calcium there. So we post-dilated. You see the valve is a little bit canted there. So it kind of straightens up, but nothing, it does nothing after balloon post-dilation. So now we have severe EI. We felt that if we left the patient like this, she would be in pulmonary edema shortly. So we took a TEE, and we can see that there's both intravalvular and paravalvular leak. I don't know why this is not running well. Anyway, so you can see in the other view there's paravalvular and intravalvular leak. So we decided that we're going to fix first the paravalvular. So we put two AVPs there, and then we still had significant intravalvular leak now. So we decided to go ahead and evaluate that with TE. You can see that there's severe intravalvular aortic insufficiency. So in this case, we decided to do a valve-in-valve. Then after the valve-in-valve, the patient looked okay, and these are the hemodynamics. So we were lucky that we were able to finish this case successfully. So final thoughts. Calcium scores are always informative, but they have more of a research purpose. I think you have to look at the CTs very carefully yourself. You have to analyze the calcium in the LVOT, the leaflets, the annulus, because they may have different implications. You have to predict. You should be able to predict the need for pacemakers when it's in the non-coronary cusp. Choose the valve you are going to use very carefully. So balloon expandable valves may pose higher risk for annular rupture, but then if you post-dilate after you get a self-expandable valve, I mean, the effect is about the same, and we have seen that. Careful decision-making during the procedure, and you have to learn how to deal with paravalvular leaks and then annular rupture, and you have to have your surgeon on your side and make sure you have a plan B in cases, in these type of cases. And then the new generation valves may yield better outcomes with less residual PV leak, and it seems that the Lotus data looks very good. Thank you.